Are we talking about divorcing ourselves from Department of Education regulations because we have commitments that are made and services that have to be provided and in a certain time frame? And, if we're having to wait on PAs, that automatically throws us outside those timelines, and then you get dinged by the Department of Education.
And that's an easy one to say, in or out. There are pluses and minuses about being involved with that. And I'd like to say our IT people, we do have some people that can set up a share site, I think, back at DHS. Where's Anna? You don't have to, but you've known them to do that, right? Because that'd be a good one to have some kind of online discussion about. Because I don't want to I can argue both sides of it, and I'm not sure I'm right either time. But I know there's people in this room that can. So that's one I'd like to hear some feedback on. This is just it's what I'm floating out here. I don't want to leave y'all with nothing to fuss about or to comment on. I know some of the other work groups didn't work like this. We did this from the beginning, so we're going to do it again. And it's not like this is a surprise to anybody. I've been pretty vocal about it since we started. That might be good to develop one model. I know we got some legal issues about CHMSs versus DDTCSs and court cases and things like that, but I think we can adjust them both to be one model if that uses the best practice. We've got a lot of folks doing great stuff in Arkansas. If it's more efficient for them to all do it one way, then let's do that. One integrated care plan. That we're working on that with the adults and the school age kids. That we don't have the therapy year or 6 months of service starting one time, the habilitation starting another, any other kind of therapy. It's not as big a deal with the preschooler kids because most of the time in a clinic setting they're only getting services there. But if you do have contract therapists or if they're going outside for therapy, we want to make sure whatever's happening to that child that's affecting his delay or his disability is in that one care plan. This is something somebody suggested to me, that we have a bundled payment for rehabilitation and that service and any services other than OT, PT, and speech. I told you before, the OT, PT, and speech, the assessments, the way that's been hammered out seems to be holding pretty well. Certainly if it needs to be tweaked for a clinic-based setting, we ought to do it. But in the other episodes that the Payment Improvement Initiative has touched, they've done similar things to where you don't change the billing method as much as you do the way the plans are made and the way people are evaluated. And so whether or not we could, right now in a DDTCS, you bill by hours. That might be the best thing to continue. In the CHMS, you bill by 15-minute units. There seems to be a disconnect there. Why we would do it different in two places. I need to hear from you on that. And then the last one, managed expansion to ensure convenient access to services for families. I touched on that a little earlier. We have due to some exhaustive litigation that I've had to sit through all of, that we ended up codifying a good bit of our expansion policy for the DDTCS programs, for our clinic-based programs. And then we further defined that in policy. And I will say that seems to have worked. I'm looking at Shelley, I don't think. At one time, prior to 2007, I was in 3 different courts on the same issue about who could expand, who couldn't expand, why did you let them expand. Since we've put that in place, I don't think we've had one lawsuit. And I know that might not mean much to y'all unless you're a party to one, but that's time and resources that aren't being spent goofing around in a courthouse and that can be spent helping children. Now, the CHMSs, I'm looking at Amy and Joy and Dan right now. Is there any rules about where you can go? Dan doesn't want to say. He's shaking his head. No, and that's okay. It's open market. That's good. But I don't know that y'all haven't been running around. Nobody's been out to Montgomery County, I don't think. So, I don't even know. I hope there's a Montgomery County since I've been using it all day. So, I've talked to the CHMS folks and talked to the DDTCS folks, and I'd like for us to have some kind of managed expansion that puts us in line with laws and rules and regulations about EPSDT, and to make sure that we're not denying somebody access, but also make sure that or does something to help encourage people to go into underserved areas. Because if you don't do that, it seems like we'll end up with a whole bunch of services in Little Rock and up around Springdale and Rogers and Fayetteville. And it might be hard to go out to Nashville and Pangburn. I don't know. We'd like to have something that helps encourage people to do that. I think the DDTCS policy does that to a degree. I'd like to hear some feedback from everybody involved on whether or not that's a good idea. I will say that as I've met with provider groups on this issue, I think the end result ought to be we have a level playing field. Because back to that slide where we talk about parents' perspective, if they call me and say, I can't get services, or the only services I can get are crummy, I don't want to go into a long, detailed explanation about how many times I got sued, the differences between the CHMS, and Mama doesn't want to hear that. She wants to hear that there's a way for somebody to expand into their area if it's underserved. But she doesn't want to hear that, well, I can have one kind but not the other. So I think we ought to try to get on everybody on a level playing field. And that's just not about expansion. That has to be about everything. And now why I decided that was important, I couldn't tell you. But I've had to answer too many phone calls from these kind of folks. And they don't want to hear me explain about laws and who develops which kind of program and what the differences are. They want to have a place to take their child, just like I wanted to have a place to help my child when she was having trouble talking. We had a long talk the other day about why transportation shouldn't be, because of the similar issue they have with the school districts that Senator Laverty championed, that I was used as an example of 10 miles in a school bus is a lot different from Monticello to Warren or Monticello to Wilmer down in southeast Arkansas than it is from Jasper to anywhere up in his area of the state. There's a huge geographical difference with regards to transportation, and we'll have to tackle that separately. I still think the equal playing field's we can't have CHMS and DDTCS on different with different resources with regards to that, but you're right, we can't bundle that service, because somebody in a urban place probably doesn't have to put as many miles on their van as somebody who's having to cover a county or two. And then there's probably pluses and minuses about being out in the county too, or out in a rural area.
A family perspective here, and I hate to use the term medical home or health home lest I be struck by lightning for bringing those up. My experience as the parent, coordination, it just doesn't exist. And I understand, DHS collects a lot of information, some of it for the files, some of it for, the prior authorization process that basically tells the beneficiary that their care team doesn't know what they're doing. Easter Seals had a wonderful team that collected a lot of information, some of which, when you ask what is it for, it was, we don't know, it's for the files. And then somewhere along there's a pediatrician. But we were just constantly faced with tests and evaluations and almost a complete lack of understanding of who's doing what and why, and where does it fit into taking care of TESA. That's what I'd like to see, is that we come up with something that everybody can use. And everybody has a little input. But if Easter Seals comes up with a plan of care, somehow that has to feed into what DHS needs for your documentation needs. It has to be something that the pediatrician can understand, because a lot of times he was signing papers once a week, but he really wasn't being consulted about that. And I don't know the answer to that, but it just seems like, we waste a lot of time and effort. And you're talking about, family friendly. Nobody understands what's going on with their child. And that really creates a disconnect between us and our providers.
I couldn't agree more, and we have not talked about that much today because we had really preached and beat on it in earlier sessions where we're talking about the adults and the school-age children. And we feel like, the school-age kids will have a health home that is housed with their case management, and our goal is just what you said. We've got to figure out what it means for a preschooler, because it is a different service. Because it's all, for the most part, what we're talking about today happens at the clinic. Now, further down the road, we're going to have to talk about kids that don't come to clinics. But we've got to keep that in mind, and that the care coordination is a piece that is real important to families, and probably real important to demonstrating that we have the most efficient method of providing service. Who's next?
Charlie, you talked about trying to combine down to one program if possible. When you look at bundling payments, are you looking at assessments that are similar to what we're doing with the adult programs? Are they going to have the different levels of care? In terms of, my thoughts is like with the CHMS clinic, is that we have children that are more medically fragile in there, and they require a lot of nursing care and a lot of social work services. Would there be a way to score that child a different level so that the funding mechanism supports having that nursing care or social worker to be involved with that child that DDTCS doesn't currently fund?
And I would hope that we can get there. The difference, and I have trouble making the bookkeepers understand this sometimes, is that the floor for this one, the minimum level of care, will still need to be a full day for the most part. I don't know that we're going to have a lot of takers for a half day. And then at some point we're making the most efficient use of our buildings and our resources. Now, I might be proven wrong on that, and y'all might be the ones to tell me that, oh no, we have a sufficient number where we could have a level of care that was basically a half day. If that's the case, I want to hear about it, because I know it's going to get brought up. We've also had discussions with Medicaid about the fact that we're able to have some higher need kids. One of the talks was the threshold we use now for Title V. We've obviously set a threshold and said certain kids are medically needy to such a degree that we'll give them special case management. Well, they probably need special care as well. So I think that's something we can talk about. Although, as long as we don't get too far off, I got to get the free daycare chest thumpers. We got to get them settled down, because the thing is, it doesn't do any good to say we're going to do a really good job with your child for 4.5 hours a day. So if you drop them off at 8:30, come get them at 1, because that's not going to work. And it's just not, and everybody needs to get over it. And I may be preaching more than I'm certainly not preaching the DHS line here, but let's not worry about that. But we know that there's how somebody spends that day, that traditional daycare day, could be a lot different based on what you just said, that there'll be kids who only get one therapy and maybe they only need it a little bit, and that what they need more is the other services. But there may be children that during that same day get a lot of therapy. They may get all three and then see a nurse. And we need to make sure that if we either can set up the bundle like that to where it'll cover it, or that we have separate tiers of reimbursement. And that's one of those things that we'll have to sit down and argue out with the Medicaid folks. Anybody else? Anybody? Dan, go ahead.
Short statement on the transportation. You know, even though CHMS patients don't access transportation equally to, or there's not parity there, the local Medicaid provider, vendor there, is still accountable for all those patients. So I know some of our Medicaid transportation providers, particularly in the Northeast, are really worried that as the squeeze comes on services, that providers try to recoup some of that by turning their patients over to NET, and which is more costly to the state than what is reimbursed in the DD model. So if we were to take all of our whatever kids, hundreds of patients, and turn them to the local NET provider, that cost is actually more to the state than if the state were to pay the CHMS what is paid to DD.
I appreciate you pointing it out, and I bet you get to point it out again in subsequent meetings. That it's hard to make people understand. We have DDTCS providers who use NET, and I don't know. I've got my own opinion about that. That probably doesn't have anything to do with economics, but if it's one of our kids, I'd like them to be on a bus with somebody that's trained to deal with one of our kids.